Hello and welcome, listeners. Today's episode is a special one. My guest and I cover a plethora of healthcare topics that relate to our patients, their caregivers, and other healthcare providers. We discuss why physical therapy isn't the only therapy you should be doing, what our overall goal is as healthcare providers, why we have hope for a future for people with Parkinson's, and ultimately how to optimize your physician visits. My guest is the head of movement disorders at Novant Health in Charlotte, North Carolina. He is on the board of the Western North Carolina chapter of the Alzheimer's Association. He has been an adjunct professor at UNC Charlotte. He is a frequent speaker at local Parkinson's events, and most recently, he volunteers all of his free time and extra energy to running marathons for Parkinson's research. In October, he will be running the Chicago Marathon for the Michael J. Fox Foundation. Don't worry, I'm going to drop some links below, so that way if you feel called to show some support for him, you will be able to do that. You're listening to Beyond the Visible, the podcast that challenges the outdated focus on just what can be seen. Here we dig deeper into the therapies, the strategies, and the mindset shifts that create real quality of life for people living with Parkinson's and other neurological disease. I'm your host, Michelle Hill, speech-language pathologist, advocate, and your guide as we disrupt old narratives and build a stronger, more holistic path forward. Let's go beyond the visible together. But a quick disclaimer before we do. The views and opinions expressed by myself and my guests on this podcast are their own and do not necessarily reflect the positions or policies of any organizations they are or have ever been associated with. Also, this podcast is for educational purposes only and should not be considered medical advice. As I'm editing this video, I'm realizing that it's a little echoey. I do apologize, I'm new at this. I have learned my lesson, and from now on, I will be wearing headphones so you don't get the echo. So I apologize for that, but now, without further ado, help me welcome Dr. Robert Wiggins. Welcome to the podcast, Dr. Wiggins.
Thank you so much for having me.
Thank you for taking the time to come here and talk to us. I know that, first of all, let me start by sharing how we actually wound up becoming colleagues. I remember getting your email from a support group leader and reaching out to you, having being a new business owner, trying to get started. And Cindy said, hey, I think you should email Dr. Wiggins. And I thought, all right, this is just going to be another one of those unresponded to emails that I send to a physician. And you actually asked me to come to your office, and you are still to date the only physician that has ever come out to meet me and shake my hand. Yeah.
Well, we certainly try our best to give everyone the personal touch. That must have been whenever I first started, because we're a little bit busier now, and we may not be able to come out for everyone. But oftentimes we try to invite people in and show people kind of our clinic space and introduce people to the team, to our small team, just to let them know kind of what we're doing. And at that time when we just kind of first started out at Novant about 4 years ago, we kind of had goals of trying to provide really great care for the Parkinson's disease community in Charlotte and the region. And it was clear earlier on that you were really trying to do the same thing. So I think that's why we have kind of collaborated so well together over the past few years.
Agreed. That always has stuck out in my mind. I remember my first impression was being, he really cares because he wants to know what the rest of us are doing to support him. In these people. And so, yeah, I agree. That's kind of what made us be collaborators, and it's amazing. So let's sort out by talking about neurological disease in general, because
Sure.
There's a lot, and a lot of people really just don't seem to understand. And I say that because I sit with these clients in therapy, and they have so many questions for me, and some of them I can answer. and some of them I shouldn't answer, and some of them I can't answer.
Yeah.
So can you talk to me about just general neurological disease and how it requires different levels of care?
Sure, yeah. So, I mean, at its basic level, neurologic disease is anything that involves neurologic tissue or the neurologic region of the brain. And so, as opposed to, things involving specifically the heart or the lungs, neurologic disease involves anything from the brain all the way to the kind of outer edges of the nervous system. So that's the brain. That's an area called the brain stem, which is right below the brain. The spinal cord, which we're all familiar with, and then coming off of the spinal cord are something called nerve roots, which turn into effectively projections or nerves that go to really all parts of our body. And so, and those nerves connect with sensory receptors and muscles and all kinds of different apparati that effectively allow us to interact with the world and sense the world and to do things. So whether the brain is involved or the smallest of nerves are involved or the smallest of muscles are involved, that is really what is neurologic disease. And there are a lot of different types of things that can affect the nervous system, whether that's infection or high blood sugar or high blood pressure or bleeds or our bodies can attack ourselves or cancer. There's a lot of different things that can attack the nervous system and ultimately cause neurologic disease.
That was a brilliant explanation, and I think that's going to be helpful to a lot of people. And one thing that I'm stumbling to be able to word this question, your nervous system kind of controls your whole body.
Right. Yeah, it does.
And,
It plays a part in all of the organs, effectively.
and so that when somebody is diagnosed with a neurological disease, and we'll talk about those here in a second, it is not uncommon for multiple areas of your health to be affected because it's involving your brain and your nerves. Can you go ahead? You were talking earlier about before we started recording about how you're on the board for the Alzheimer's Association of the
Right.
Western North Carolina. Alzheimer's disease is a neurological disease, and so is Parkinson's, which is
Right.
how we came to know each other. Can
Sure.
you talk about some other neurological diseases that are impacting our community right now?
Yeah, absolutely. So, Alzheimer's disease is a type of dementia that I'm sure we'll touch on more, but everyone is very familiar, at least knows that word. There are other neurologic diseases that are present as well, whether they're, not necessarily life-threatening, like something like neuropathy. I mean, probably the most common neurologic disease in the world, or at least in Charlotte, is probably neuropathy. And neuropathy is just a disease of the nerves, and
Yeah.
that's oftentimes where people will have either burning sensation or will have numbness, or really that it kind of ends up making people not be able to walk very well because they can't sense the ground. So that's a very, very common one.
Yeah.
Outside of my kind of subspecialty or small area of neurology, there's also seizures or epilepsy where people's brains can actually kind of start misfiring and the electricity doesn't work quite as well as it used to. And people can have convulsions where people will shake, or people have times where they are kind of unaware of the world or they're confused for a while. So that's epilepsy. Or another condition called multiple sclerosis is another thing that oftentimes happens. And that is actually where our brain and our spinal cord is actually being attacked, like by kind of the immune system. And another one that we're also familiar with is strokes, right? And so whenever the
Yeah.
brain or the spinal cord doesn't get the right amount of blood, whether that's too little blood, where the brain tissue or spinal cord is being starved, or too much blood when there's kind of a bleed going on. Both of those are major types of strokes that can happen. And effectively, Michelle, I think you're right. The reality is that all of these neurologic diseases affect the brain tissue or the spinal cord tissue or the nervous tissue. But those areas of our brain, of our body, control so many areas of our lives, right? And so when someone has a stroke, it's not that they are just purely weak or they are numb. They also can have changes in their mood, right? The brain controls depression and our mood and mental health conditions. So it's really, really, really complicated, which is why I think that, one approach is just to look at neurologic disease as just the brain tissue, just the nervous tissue. Or another way to look at it is to say, hey, okay, this is a more complicated issue and there's a lot of factors going on, and to try to really offer not only a whole patient or whole person approach, but really try to understand that the patient is certainly affected. Well, their family is also affected. Their career is also affected. And, Michelle, it's really easy to talk big thoughts like this and really talk about how we should be doing this. But I think oftentimes it's actually incredibly difficult to put these lofty words and lofty goals and missions into actual practice. And that's something that we're trying to do. I think we oftentimes fall very short of what patients hope we do, what we wish we had done, maybe sometimes what we try to promise, I guess. But it's certainly a good mission field, so to speak, and it can be taxing and tiring. But I'm certainly really thankful to be in this line of work.
Yeah, I think I love what you just said. It is taxing, and I think what brings the two of us together so well is that we both love what we do. We all rely on each other to help paint the bigger picture. And you're right. I do think that our patients wish that we could, all talk to each other all the time. And sometimes I wish that too, right?
Yeah.
So that we could, do that holistic, whole person care at the same time. Yeah. And that's part of the mission of the podcast here, is to talk about why we can't right now. The healthcare system, and it's not the hospital system, it's just kind of the whole insurance plus everything else keeps us, we have to stay in our lane.
Right.
We have to stay in our lane. But we try the best that we can to communicate with each other. And that's why I really grasp onto and tightly hold on to practitioners like yourself who are willing to collaborate. Because I think, it can only make things better for all of us. But
yeah, I mean, I might add that, initially it may sound like, staying in our lane is a bad thing. Sometimes I think we do try to only, I probably sometimes am overly like, oh, I can't help with that, you need to go see someone else. But there's some benefit to that as well, saying like, hey, you don't want your cardiologist treating your Parkinson's disease. You don't want your neurologist treating your heart failure. I have special expertise in certain things, and they have special expertise in other areas. And I think you're right. It certainly, we can all say that communication and interdisciplinary or multidisciplinary teams are the best way. And I agree. I think that one of the issues is that there's not a lot of us. There's not a lot of practitioners. There's not a lot of physicians. There's not a lot of nurse practitioners, physician assistants, speech language pathologists. There's just not a lot. And so a lot of these people, particularly the folks that are really trying to offer really high level care, it's sometimes maybe challenging to provide all of that perfect communication that we need to. And maybe I'm getting a little too personal here, but it's challenging. And I think we oftentimes wish that we could communicate more than we actually have the time for, based on just the number of people that we would like to communicate with, as well as some of the other pressures that exist in our daily lives and in our professions as well.
Yeah, this is kind of, I think you should come back and we could talk about this whole thing. And I don't believe it's too personal, because I think that there are a lot of practitioners, and I certainly was one of them until I let the business go, where I tried to do it all. It's well-intentioned, and you talk about not wanting your movement disorder specialist treating your cardiac problem. Well,
right.
I feel the same way about the physical therapist treating the voice problem. Right. Don't do it. That's my job. Right? I think that anybody who's listening to this episode would benefit from hearing the other side of the beyond the visible part, right? And that's one of the questions I get to later on, is like, our patients come in, they sit down, they see us come in the room, we provide the evaluation, the treatment, the recommendations, but they don't really see what's happening behind the scenes.
Right.
And going on the point where there's not a lot of us,
Kind of quick comment on that.
Yeah.
We talk a lot. One of the things that I know you really value is making sure that caregivers don't feel necessarily overburdened, right? Or maybe said differently, realizing that caregivers are overburdened, and they can oftentimes burn out. Well, I think that there's a whole nother conversation, perhaps we can talk about another time, just about healthcare providers becoming burnt out, and that's kind of in the news a lot lately. And I kind of say, just like you want your caregiving wife to be there in 15, 20, 30 years for you when you will really need them, you also want your amazing level A, top, best in the county speech language pathologist to be there in 15, 20 years when your dysphagia or your hoarseness worsens, right? And so I think there's something to be said about, I think healthcare providers also need to make sure that they're taking not only excellent care of their patients and those who love their patients, but also really trying to take nearly excellent care of themselves, right? So that we will be there, and so that the small number of healthcare providers now focusing on, say, Parkinson's disease will either stay the same or grow. Whereas I think oftentimes at our current rate, it will only shrink, or that's my concern.
Oh, yeah. I've heard reports of OT programs being, their enrollment being half of what they were a couple of years ago. The pandemic, I think, really did a lot to highlight caregiver burnout and healthcare provider burnout, and really kind of ignited us to see things that just haven't been working, but we've kind of been dealing with anyway because we felt like we had to. And then we realized this isn't sustainable. It's about putting your own oxygen mask on first. You can't give from an empty cup. How many times have you heard that? And healthcare providers are the same. So if you walk into your healthcare provider's appointment and they look tired, stressed, overwhelmed, and might not be as enthusiastic about the visit one day, perhaps that could be a consideration on the other end. It's like, ooh, maybe somebody needs a break, right?
Yeah, and it's kind of this desire, I think, that healthcare maybe one day will return to being more relational between two human beings, one who has a condition, one who is an expert at that condition, and really can kind of meet in the middle and talk about these conditions and help one another. Whereas I feel oftentimes nowadays healthcare is just very transactional. Not only is it just kind of you pay a copay at the front or whatever, but oftentimes, people, I expect something from them and they expect something from me. And I think that, Michelle, we'll have to talk about that another time, but
Right.
but it's certainly, no one wants their mother to be taken care of in a transactional relationship. No one wants their mothers to have their health taken care of in a transactional way. And so certainly the system is broken, Michelle.
I'm here for the change. I've determined that is part of my purpose in existence, is to help facilitate or do whatever, shout from the rooftop until things start happening. We can talk about that another time too.
Absolutely.
All right, so now let's kind of go back to neurological disease.
Yeah, sure.
Your specialty area of expertise is in movement disorders, specifically Parkinson's disease. And please know, everybody, listener, that Parkinson's disease is not the only movement disorder. But can you talk about what Parkinson's disease is and how is it different from other neurological disease?
Sure, yeah. So Parkinson's disease is a disease that we kind of think mainly attacks or involves the brain. And there's very small areas of the brain that we think cause some of the movement symptoms or motor symptoms that traditionally people kind of look around and may say, oh, he may have Parkinson's disease because he's shaking, or he's slow, or he's stiff, or he's having walking trouble. Of course, there are many more symptoms that people can have who have Parkinson's disease. And interestingly, we don't necessarily think, or the leading scientists who are much smarter than I am, don't think that Parkinson's disease starts in those areas. The thought is that maybe it actually could start in the gut, or actually start in kind of the nasal passage and work its way up the olfactory nerve, or the nerve that helps us to smell. And so we're learning a lot more about Parkinson's disease. And the reality is that there's probably different ways that Parkinson's disease actually happens. But Parkinson's disease is a condition that not only affects, the brain and causes those motor symptoms, but leads to so many other symptoms that patients can have and have to kind of deal with. And it's different in that, I guess there's a lot of ways that it's different, but one way that it's different is it can be all-encompassing. There are a lot of symptoms that involves. It's different than, say, just pure neuropathy, where just kind of one area of the body is affected. Parkinson's disease can, on its own, cause neuropathy too, and can cause cognitive troubles, and cause hallucinations, and walking trouble, and bowel and bladder issues, and blood pressure issues. So it's really an all-encompassing disease. But, Michelle, if I could say, too, that one way that it's also, you could say, different from a lot of neurologic diseases, there is so much new research over the past even year. I mean, this has been a remarkable year for Parkinson's updates and research, and there's a lot of exciting things happening. And so there's certainly hope outside of the Parkinson's disease world in neurology, but I certainly have a lot of hope within the Parkinson's disease world. I'm very optimistic to see how things continue to improve for patients.
I can't wait to hear all about that. That's a question listed later.
Okay.
And also, I think it's really important to highlight the hopefulness. That is something that with my pulse on the clinical end, seeing patients through the week, and you are too, I have a little more opportunity to chat more so. There are a lot of people out there feeling pretty hopeless right now. So I'm really excited to hear what tidbits of hope you have for the rest of us. Yeah, I mean, in the grand scheme of overall time and the existence of the universe, Parkinson's disease has only existed for a little bit comparatively. However, within our time, this is one of the oldest neurological diseases, and it's very well researched, and we've continuously got more research going on. Can you talk a little bit about, I'm skipping ahead, but can you talk a little bit about the research that is coming out, the new stuff that might help people?
Yeah, so the way that I look at that is maybe twofold. One is symptomatic treatment, so ways that we help patients feel better. And then you could say maybe also more, whether it's disease modifying or really more disease centric treatments, where we're trying to say, okay, why do people have this condition in the first place? How do they get it? And then what do we do about it? And is there a way to slow it down? From a symptomatic perspective, I mean, I'm gonna forget one because there's so many, but there are so many new innovative ways that we're treating Parkinson's disease now. So, we have had decently effective medications, but there are always ups and downs with those medications. And when I say ups and downs, I almost mean literally ups and downs, in that people's medicines would work really well for a few hours and then wear off. Well, two kind of major advancements lately have been the adoption of what we call subcutaneous pumps or subcutaneous devices, where two different kinds of medication, whether it's a levodopa or a apomorphine, which is a dopamine agonist, are actually slowly infused into the body via just a little small, I kind of call it a little antenna, going into the belly or different parts of the body that slowly provides the good medicine throughout the entire day. So that's one exciting thing. And then also deep brain stimulation, which we've known about for a long time, has, just radically taken major steps in the past year or two. So one being that we now look at deep brain stimulation a little differently, in that, rather than saying, okay, I kind of understand the brain anatomy via a textbook and I think I know where these leads are, we're actually looking and knowing, no, here is exactly where it is in the brain, and I understand exactly where this individual brain tissue is. and I can send signals here and there and change the signal. So that's one advancement. And then now there's a new technology called adaptive deep brain stimulation, where we think about, rather than just kind of providing constant stimulation, maybe it can shift and move and go up and down based on a patient's needs. So these are brand new technologies that are quickly being adopted, or at least looked into, to try to help patients. So I know I'm long-winded, Michelle, but those are the symptomatic side of things. And then the other side of things from why did I even have Parkinson's disease to begin with? One of the really, it's already kind of making the New York Times bestseller list, is a book lately called The Parkinson's Plan, which effectively is suggesting or theorizing, saying that, hey, this condition, though it's well researched, it has not been around forever, right? It's a newer you could say it's a newer condition, and maybe some of the reason that's happening is from reasons like pollution or toxic exposures that we are exposed to in our lives, and so thinking about those ways to say, hey, let's change that. Maybe there are ways to change the world that we live in, are super exciting, and really may lead to major changes for not only people who have Parkinson's disease now, but what if we can live with a world where Parkinson's doesn't really exist, or it's mostly purely a genetic phenomenon?
Yeah, yeah. The Parkinson Plan. I follow that author. He is at the Norman Fixel Institute, right? Michael O'Keen. I can't remember his name.
It's Oken. There's two different authors. One is Michael Oken, and then another is Ray Dorsey, who have collaborated on other books before, but they're really excited about this idea of, this isn't the way it's supposed to be, guys. And this is, the Parkinson's disease is not just a disease of the elderly. I saw a patient earlier on this week or last week who, to be somewhat general, is in their 20s and 30s, and I'm wondering if they may have Parkinson's. And so it's not a disease of the elderly. It's a disease of humans, and a disease of potentially the world, and ways that our world is harming us.
Yeah. The study that came out about golf courses, that you're 6 times more likely to have Parkinson's if you live within 6 miles, 10 miles of a golf course.
I don't have the number right off the top of my head, but yeah, it's within 6 miles you have an increase. Let me not quote the exact numbers, but whether you're in a certain radius of a golf course, you have a higher chance of having Parkinson's disease, and those authors really are suggesting it's probably related to pesticides and other things that are being sprayed on the golf course.
Yeah, and so I was just getting ready to connect those dots. It's like, okay, so maybe you don't live within 6 miles of a golf course, but if you're using the pesticides and the herbicides that the golf course is using, you're more likely, probably at higher risk. I've been screaming for years that it's our food, it's our food, it's our food, but I don't know that it is our food. It might be part of the food because we use pesticides on our food. But I'm with you. How about we live in a world that doesn't even have this disease? But let's do all we can to help the people who actually do have it right now.
Yeah, absolutely. And I would just emphasize again that I will forever have optimism and hope in this area. And I truly believe that, and I know that I'm currently training and working with a new nurse practitioner, and we at least 2 or 3 times a day will walk out of the room and say something like, "This is why we're doing that. This is why we have chosen this career." And there were a few tough visits earlier on, but that person we know we're really helping, and they're appreciative, and we need to help this person.
Yeah, I love those moments. They just make you feel so good. It's like, okay, this is why. Yeah, okay, good.
Yeah, helps you to do at least another day.
Right. If not another patient sometimes. All right, now, you are a neurologist with a specialty in movement disorders. Can you tell the audience the difference between a primary care physician, a neurologist, and a movement disorder specialist, and then why somebody with a movement disorder needs to see you instead of anyone else?
Sure. Well, of course, it's part of a team, right? We want everyone to be involved with several different teammates, but a primary care physician is a physician who has gone to medical school and has gone to residency, and their focus, you could say, is typically on general health. So they're worried about some things like blood pressure, diabetes, thyroid issues, weight, cholesterol, etc. Kind of your whole body health. This is the person that you typically go to for your annual physical. This is the person that you typically go to whenever you think you may have pneumonia or COVID or something like that. Those physicians are the ones that oftentimes will make an original referral saying, hey, this patient has a tremor or is having trouble walking. And in the way that it works, at least in America, that person will most oftentimes be referred to a general neurologist. Neurologists are, there's also not a lot of neurologists, but there's more neurologists than, we'll say, movement disorder specialists. So just by sheer numbers, they'll end up going to a general neurologist who has done typically 4 years of residency training after their medical school, focusing on neurologic disease like we talked about earlier on. But that's, you could say, more of a general neurology exposure. So they're kind of a master of several, or they really try to focus on a lot of different conditions. So they're going to know a good bit about epilepsy, a good bit about multiple sclerosis, a bit about Parkinson's disease, a good bit of Alzheimer's, all of the conditions. But then where I'm different from a general neurologist, so after my residency in neurology, where I did the general stuff, because I enjoyed treating people who have Parkinson's disease, did another, span of training, which for me was 1 year, to focus really only on movement disorders. So the most common of which is Parkinson's disease. And so effectively, I can treat basic seizures, basic epilepsy now. I can treat, there's oftentimes not a lot of Parkinson's problems that are, that I've not encountered before, that I'm not familiar with. And so I'm a great Parkinson's disease doctor, I think. I'm not a great epileptologist or headache doctor. And so that's kind of how they're different. So why should you see a movement disorders neurologist? Well, oftentimes, the new medications, all this new innovative stuff that I'm talking about, that's stuff that I'm familiar with. And not because of a lack of interest or intelligence by any means, but the general neurologist, and certainly a primary care doctor, just is exposed to way too many things, and they just are not able to put the time and attention into this new therapy or whatnot to really know what's best. And so I don't think it's bad to also have a general neurologist, maybe like a local neurologist, but I do think that the majority of my patients are seeing only me as a neurologist. They may have other neurologic conditions they're being seen for as well. But really the movement disorders neurologist is there at least to try to set you on the right course, try to provide good recommendations, and if not, provide some of the more like week-to-week, month-to-month care, at least try to provide a general, this is where we're heading, and actually those medicines we used 10 years ago, we try not to use those anymore, we're using these newer medications.
Yeah.
And so that would be the reason to have a movement disorders neurologist or a movement disorder specialist involved in your care.
Okay. And so now, with that being said, right, you have a specific role within the ideal multidisciplinary care team. Aside from, talking about the trajectory, where we're going, this is the medication we're going to use, these are the therapies I recommend in managing the movement disorder, what is your role in that multidisciplinary team? Would you consider yourself the point person?
I think that I would say by default we end up being the point person most often. I think because everyone needs medicines, and so they've got to come to me.
Yeah.
And I think that whether we could be seen maybe like a grandmaster coordinator, like we're trying our best to not only do the medications but help funnel people in the right direction. And so, Michelle, one of the most common things that I hear from patients who I recommend go to physical therapy will be, oh, I did that and it didn't help. But then you kind of investigate a little further and you realize, oh, well, that patient was sent for their Parkinson's disease freezing of gait, and they saw a wonderful orthopedic physical therapist who really made sure that their knee pain was minimized, or really made sure that there was their knee pain or their arthritis was treated well. And so, not that the orthopedic physical therapist did anything wrong, but they may have just been the wrong person. And so, trying to say, I know that you have been to physical therapy before, but that was probably the wrong kind of physical therapy. And if we can find you someone that's hopefully close to your home, that really specializes in Parkinson's disease, and we know many in this area who are really good, and really try to find someone that knows what they're doing and is really going to kind of go to bat for you, trying to say, hey, let's go to them instead. And so, yeah, we could be the point person, and we're trying to find, our clinic is a small clinic, and we're trying to find ways to really kind of combine resources with other groups, trying to find out whether it's local Parkinson's organizations or national Parkinson's organizations to try to help our patients get the best things they can. And so that's our role. And then ultimately, I would say, rather than point person, we oftentimes try to be the cheerleader and just try to really encourage people to keep going and that kind of a thing.
I feel like that role is definitely appreciated. The cheerleader role, like you got this, you can do this, keep going.
Yeah, I think that, this is a tough condition, Parkinson's disease, and I think it's very easy for patients and those who love them to get to lose hope and to become pessimistic. And Michelle, let's be honest, we're not living in the day-to-day of this disease. We're seeing it all day, but oftentimes that's, for me, it's a 20-minute moment of their life, and it's probably shorter than that, right? But I think that we can certainly try to provide some encouragement, as long as it's not cheap, fake encouragement, right? Like all of the encouragement that I'm providing, I'm trying to be. No, there are a lot of great things out there coming out, and I have seen some great stories where people do feel a lot better after they start this medicine, or people do stop choking after they see a speech language pathologist, right?
Yes, they do. I have a good report from a client I saw yesterday of yours who is no longer choking. I mean, hey, we do what we can, and I think too, we're not there day to day. You're definitely not. You get to see them for 20 to 30, maybe 45 if you're lucky, minutes every 6 months.
Much shorter. Yeah, our follow-up patients are oftentimes, they're slated for about 20 minutes. And probably even around us, most health systems allow 20 to 30 minutes for a follow-up patient. But the thing about that, Michelle, is that it's shorter than 20 minutes. Like technically, I'm supposed we can talk about some recommendations I have for patients, but typically that 20 minutes includes them being checked in, them being roomed, them having their vitals done, going through their medications, their time with me, and then in all honesty, I'm supposed to have my note done for them at the end of that 20-minute visit. Otherwise, I do it, at 6 p.m., 7 p.m., 8 p.m., or 9 p.m. And so it's really much shorter than 20 minutes, most likely, for follow-up patients.
Yeah, and that kind of gets into another episode about the invisible side of your physician-doctor visit. We are dictated how long we can spend with our clients. Now, I have been extremely lucky, and one of the reasons why I left the healthcare system was because, I didn't want to be told what to do. I didn't want to be told I could only spend 15 minutes with my client. That goes to the other unseen side of things. We would love to spend hours. We would love to be able to answer all the questions and really take the time to get to know a little bit better what's happening. And when we talk about follow-up visits, I typically strongly recommend to my clients, especially when they have a lot of questions for me. they'll ask me questions about medication, and I don't know about medicine. I can't prescribe medicine. That's a question for Dr. Wiggins. That's a question for your movement disorder specialist. And they'll say, oh, I've got an appointment coming up. And so if I'm working on cognitive therapy, I say, okay, what questions do you have? Let's write them down.
Right.
Are there some questions that you would recommend? Like, we can only ask questions about things that we know to ask questions about. Are there certain things that you're finding that our patients are just, they don't know to ask?
Yeah, I think that it's really important to come up with that list of questions, like you're saying.
Yeah.
I'll be honest. At the beginning of my career, I hated that list of questions, but
Yeah.
now I have. But now, honestly, it is the best thing because I know what they actually care about, and so
Yeah.
and I know that we will leave that visit, and they will have felt cared for and listened to, and that's the whole goal of the visit. I feel like really. Yeah, I think typically in Parkinson's disease, the things that I don't know if people are really asking directly, but maybe should be, or like my framework is like from a medication perspective, are my medicines optimized? Like they're not going to be miraculous drugs, right? They're not going to cure you, but are they
What?
doing what they're supposed to be doing? And
Right.
am I at the right dose, too high, too low? Are the medications doing what they're supposed to be doing? That's the first thing. So that's the medication part that I can speak to. And then the other thing is really, am I doing everything that I can be doing? So is my exercise level enough? Am I pushing it enough? Am I active enough? And when I say exercise, and I think I really mean incorporate all kinds of, we'll just say activity. So, am I challenging myself enough cognitively? Am I really trying to, as long as we're safe and not falling, right? Am I
Right.
doing the things that I can do to challenge myself and to push myself, or am I just saying, I'm going to sit on the couch today because I'm a little tired today, or whatnot. And so, are your medications optimized? And then, am I optimized? And then, I oftentimes find that people, understandably so, really focus on, well, what is 10 years going to look like? And what is
Yeah.
15 years going to look like? And that's just so challenging to answer that my recommendation oftentimes is say, like, gosh, well, let's just focus on the next 6 to 12 months and what that's going to look like. I think I'm much more accurate, you could say, looking outside and telling you whether it's going to rain in the next 2 or 3 hours
Right.
rather than knowing what the weather's going to be like in a year. And so we can definitely help chart a course, but I think that would be another kind of question is just maybe thinking more short-sighted, short-term, short to
Yeah.
medium term.
Yeah. Taking focusing on the next step versus the whole entire staircase.
Yeah,
And
yeah, exactly.
I've had clients ask about, well, they tell me that they can't predict what's going to happen in 10 years. And I say, well, yeah. I mean, even this is not just Parkinson's either. This is Alzheimer's patients of mine. And I'll say everybody's brain is different.
Right.
So it's impossible. It is impossible to predict how this one disease is going to affect your brain because the way it affects everybody's brain is really different.
But we do
Right?
know that you're totally right. But we do know, like, you can take care of your brain in certain ways. And so, though we
Yes.
don't know what the future is, we know how to make it worse, and we
Right?
know how to make the future better. And so, I just think that everyone, we kind of, don't you think, Michelle? Sometimes, even, I mean, myself, maybe yourself, I oftentimes know what I should be doing, and I sometimes do it or don't do it. And I think that's the important thing to focus on is not necessarily what it will be, though that's important. Obviously, there are financial things, care, planning
Right.
things, legal things that need to be thought through. But what can I do today to make tomorrow as good as it can be? And what can I do today to try to prevent the bad stuff, or at least reduce the chances of the bad stuff from happening. And so it's not this, can't predict the future, or all is lost. It's more of a, no, we can, we know how to make the future better. I have this phrase I say: we can be good at being active and exercising, or we can be good at sitting on the couch. And I think that all of my patients probably in 10 years want to be good at moving and being active and exercising. But oftentimes the choices, at least I make in my everyday life, oftentimes help me to be better at just sitting on the couch. So we all kind of need to work on this.
Oh, yeah, we do. Hence my tea instead of cup of coffee. Yes, I think you're right. We all struggle with that. I know what I need to do, but it's even like when you think in the mindset direction, right? It's slipping back into that old pattern. When you slip back into that old pattern, it's comfortable, it's easy. I know what to do there. I know how I feel there. But when I exercise, I get sore. When I exercise, my back hurts. And then they hear me and the physical therapist, and I'm going to guess you, well, if you would exercise more, your back might not hurt so much.
And also, some people feel the best they will feel all day during and after exercise. And so, yeah, you may have some joint trouble, some this or that. But a lot of people say, gosh, they'll say, I've not been feeling well lately, but I know I haven't been exercising. Mm-hmm. And I know that if I start my exercise again, I will feel better. And so, yeah, they say, Michelle, no, I'm no joint expert, but I think I remember hearing that, like, the way to address and treat arthritis, at least mild arthritis, is to exercise and to move and to strengthen the muscles surrounding the knee and the joints. And so, yeah, oftentimes exercise may have some short-term discomfort, sweating, joint pain, back trouble, here or there, but pretty quickly I'm convinced that the good parts about exercise come pretty quickly. It's not just, you'll have better Parkinson's in 10 years. It's, no, you'll probably feel better today, or at least tomorrow if you exercise.
Now that we're talking about exercise.
Yeah.
Talk to me about what happens in the brain when we exercise and why that is good for neurological disease, specifically people with Parkinson's.
Yeah, well, I don't know if I can tell you exactly what happens at like a cellular level, but in a way I would say it doesn't matter because we know that people who are exercise have better Parkinson's or less bothersome Parkinson's disease in the future. We know that it's neuroprotective. And I would also remind people that, yes, outside of Parkinson's, but it also reduces the chance, or it reduces other neurodegenerative conditions like Alzheimer's disease. Mm-hmm. And we know that, the more that someone is active, the better their life will be, the less they will fall in the future, and the better their neurodegenerative disease will be. And so, I like to be very honest and transparent. I don't know the specifics about that. I don't want to make something up and hope I get it right. But what we do know is that it works. Yeah. And we all know that it works, right? And even if we like can't wait for that 10 years of improvement, I just kind of remind everyone again, to be a broken record, you'll probably feel better today. It's probably worth it today to do that.
Yeah. I like to quote one of my favorite movies. It is Legally Blonde, and she's in court, and she says, exercise gives you endorphins. Endorphins make you happy, and happy people just don't kill their husbands.
Yeah, I think that analogy fits. Even outside of murder. But
Right.
I think that it creates happier people, and we hear kind of all the time, exercise works really well, even in comparison to antidepressant medicines, anti-anxiety medications. Of course, I am not saying that people should not be taking antidepressant or anti-anxiety medications, but yeah, exercise actually will help with those. Michelle, I know that when I'm in my worst mood and I'm at my saddest oftentimes, there are two things I need to think about. When was the last glass of water that I drank?
Oh,
And
yeah.
when was the last time that I exercised? And oftentimes, I've not had water and I've not exercised in a few days. And if I can correct those two things, I'm not going to be, my most joyful, but at least I'll feel a little bit better.
Yeah. Talking about
Hmm.
neuroprotection, right? I've been talking about this with all of my clients. For some reason, 2025, I'm obsessed with cognition. I feel like this is where us as therapists are we're not failing our patients, but we're missing the mark here as far as cognition goes because we're trying to address it. And I don't think our clients understand why we want to address it and why we want to address it before we see deficits.
Sure.
But when we talk about neuroprotective strategies, exercise is one of them. Diet is another one. And it's not keto, it's Mediterranean or the DASH or the MIND diet, they're all versions of the Mediterranean diet. It is using your brain for something different,
Right.
social engagement, and depression, right?
Yeah.
Depression affects the way that we think. And so does anxiety. And anxiety is one of those invisible symptoms, as I like to say, about with Parkinson's. My goodness, if my grandfather got a penny for every time he was worried about something, I would have an unlimited inheritance.
Yeah.
But even so, that anxiety becomes absolutely debilitating for some of our clients. And they don't realize the significance of how exercise can help that.
Hmm.
And then also surrounding yourself with other people and even getting out of that negative feedback loop by doing something different,
Totally.
forcing yourself to think about something different. Exercise is just such a good way, at least for me. And I have read in multiple resources where if you're feeling anxious, go for a walk.
Yeah, I think those are tools recommended by like licensed therapists and counselors too, which is another, I think, maybe an underutilized resource in the Parkinson's community is therapy. So we talk about physical therapy, occupational therapy, speech language pathology, but we oftentimes don't always think about therapy, like talk therapist or counselor, social worker, that kind of a thing, which can be
Yeah.
really helpful. Michelle, I think that in America, at least, the number one cause of memory trouble or cognitive trouble is actually not Alzheimer's disease. It's probably depression and or anxiety, the number one cause of all people. And in Parkinson's disease, depression and anxiety are very, very common. We talk so much about dopamine in Parkinson's disease, but we oftentimes forget about serotonin. And serotonin levels are affected in Parkinson's disease and we think, can directly contribute to things like depression and anxiety. And so, gosh, yeah, it's just so important to not just think about the motor symptoms, the carbidopa levodopa symptoms of Parkinson's disease, but really think about all the other issues. And that's, to go back to your earlier question, I think that's where a movement disorder specialist is kind of well trained, because even now as I'm talking about, say, anxiety, I'm thinking, well, we talk about serotonin, but it can also be related to dopamine levels, right? And so
Yeah.
if your medicines are too low at certain times of the day or all day long, you can be very, very anxious, and you can look like you're having a panic attack, and it might just be your dose is too low. And so it's just such a complicated disease. Michelle, I would maybe kind of as as just a summary statement of this moment is like, don't go it alone, right? You certainly
Right.
cannot do this alone. And also, just don't do it with just your spouse or your child. There's a lot of resources out there, and that can be helpful. And I, I think I think at times I feel like our region can sometimes be like a. Sometimes it feels like there's not a lot of resources, but other times it feels like there's a lot of resources. I kind of go back and forth there. But what we know is that there are resources out there, and there
Yeah.
are groups specifically that exist to help people and these exact situations and conversations that we're talking about. Yeah. We should talk about OT and speech though.
So tell me why speech therapy and occupational therapy are just as important, if not more, because I like to think of myself as really important. Why do people need more than just physical therapy?
Yeah, well, people need more than just their Parkinson's doctor, first off, and I think they need therapists. And just Michelle, just like I was saying, don't let your cardiologist treat your Parkinson's, and don't let your your Parkinson's
Yep,
doctor
I know.
treat your heart. Physical therapists are so well equipped to treat symptoms and things that are handled by physical therapy, right? And gosh, they're so wonderful, and that includes things like maybe strength in certain areas or walking and mobility. Those are so important, and we're so used to physical therapy because we maybe did it earlier on whenever we had a knee issue or something.
Right.
But what we have to remember is that there are other areas of Parkinson's disease beyond just kind of gait and strength, right? There are issues like trouble dressing, trouble getting one's words out, trouble swallowing, trouble showering, trouble with one's cognition. And, we have to try to let the physical therapist stay in their lane and pursue other types of therapy. And so, I think that a lot of times people will ask me like, oh, well, what type of, what can I do for this situation? Like I always fall getting up from the toilet, or I fall in the shower, or I have this issue or that issue. Well, I'm not the best one to answer that question. I can throw out a general answer of like, oh, go buy some grab bars. But that's, actually an OT in our area kind of mentioned this, that it's not just that simple. Well, where do the grab bars go? How
Yeah.
how strong do the grab bars need to be? And what orientation should they be? Should they be perpendicular or horizontal? I don't know that.
Yeah.
And then, the about all I can say whenever someone is having swallowing trouble is chew slower, or swallow, chew more. And then, honestly, my expertise is gone, is over at that time. And so, really taking advantage of someone who has spent their life looking at, Parkinson's disease-related swallowing trouble, or Parkinson's-related voice troubles, or Parkinson's disease-related cognitive troubles. That's really important. So, effectively, maybe one way I could summarize this thought is like, if you want your condition or your symptom handled the best, you need to make sure that you're going to the right person for that. And maybe the first step of that is recognizing what symptom you even have to begin with, which is where I think that list of questions that you had mentioned earlier on kind of comes in handy here.
Yeah. A lot of people, at least it's been in my professional experience, just swallowing in general, people think it's part of aging. They don't
Yeah.
think there's anything that can be done about it.
Right.
Yeah, when I go to the support group talks, I talk about, yeah, when you can't walk, it is terribly inconvenient. You get a wheelchair, but you get a wheelchair. What happens when you cannot swallow anymore? You have to choose between death and a feeding tube, and a lot of people don't want the feeding tube.
Right.
And there are so many things, as you know, because you've seen my reports. There are so many things that we can do to help an individual who is having trouble swallowing. Even at the advanced stage of Alzheimer's, sure, we're not going to be able to cue the patient themselves to, swallow hard, because they are not at the point where they can follow directions. But we sure can talk to the staff, the caregivers, and show this is how you can get a swallow when they're just not swallowing, and you can't tell them to swallow, right? There's a bunch of things that we can do, and it's just I think it's important, too, Darcy and I talked a little bit about the occupational therapy scope of practice, and a lot of people want me to help get the food from the plate to the mouth.
Yeah.
No, you need an OT for that. And I can say, well, I know that there is some special utensil that you can buy, but, going back to staying in our lane, I don't do a lot of research on those utensils because I'm looking at the research on voice and swallowing and cognition, right, and doing that stuff. So that's where my focus is. So I'm going to refer, or, I say, okay, I'm going to send Dr. Wiggins an email. I want you to follow up and say, we want a referral for occupational therapy or right, a dietitian. That's something that we haven't really touched upon, which would be another interesting episode, is, weight loss with Parkinson's and requiring some additional knowledge. Yeah, I know a lot about swallowing, and I know a little bit about nutrition, as in you need more fat and protein, but I can't tell you much beyond that.
Yeah. Yeah, it's challenging, and I think, Michelle, you're much more of an expert given your field of expertise here, but like, the other thought is like swallowing, eating, taste is just such an integral part of our joy and happiness.
Thank you.
Yeah.
Yes.
And so it's like, yeah, I mean, these are things like we say that, oh, we want to, oh gosh, I want to be able to walk my daughter down the aisle or something like that. Well,
Yeah.
you also want to enjoy the wedding cake.
Right.
And you want to be able to enjoy that meal of your child or grandchild's wedding. And so, yeah, so I don't know if you have any thoughts there, but it just feels like, you know, we can look at swallowing maybe, and even hoarseness as mechanical, like on the mechanical side of it. But there's also a whole nother part of personhood and feeling like I am joyful and I am here and you can communicate with me. I don't know. I don't know if you have thoughts on that.
I have so many thoughts. But yeah, I mean, it comes down to quality of life. I will joke around with people and say, I dare you to tell me I can't drink coffee. I dare you. Because come the end of my life, if that's the last breath I take, I'm taking the coffee with me. Food and drink revolve around every single one of our special occasions. I would love to challenge anybody in the comments to come up with one single event that we have that does not involve food and drink. We have a family get-together, we have food and drink. 4th of July, we have barbecues, funerals, weddings, all of the things. We eat. And then there's a lot of people who are afraid to say, I can't eat that. So then they try to power through it, and then they have a choking or a coughing episode that scares everybody. And then they quit going to these functions.
Right.
And I don't enjoy being the person to paint doom and gloom, but there is a negative cycle that starts to happen when you stop going out, when you stop socializing.
Right.
And if you're difficulty chewing or drooling even, I've had people say, I won't go out with my friends anymore because I can't stop drooling. When you stop going out with your friends, earlier we talked about social engagement being one of those neuroprotective strategies. Now you run the risk of depression and cognitive decline. But I see that
there's so many aspects of Parkinson's disease, and you don't want to miss out on one of them. You don't want to not be able to swallow. You don't want to not be able to communicate. You don't want to not be able to walk. All of these things. And I oftentimes will tell my patients, with whether it's drooling or they're worried about they're socially conscious of their tremor or something, I like to say, just remember it's the year 2025 and no one's actually focusing on you. They're probably looking at their phone, or they're worried about what you think about them. And so it makes sense that people are concerned, but in all reality, no one's probably noticing. And then the second thought is, even if they are, screw them. Like
Right.
who cares? Like I know I'm saying that somewhat comedically, but like the idea is, if being getting out there and being social and being engaged is going to help your brain, then you get that. You deserve that. You go for that. And
Hmm.
if they're going to look at you in a different way or whatever, well, that's their problem. Screw them.
Right.
You're entitled to things that are going to protect your brain, right? That's going to make your body better.
Yep.
That's allowed. At least in this country, it's allowed.
I echo your sentiment. Who cares? And I keep saying that. I will give you all the strategies I can to help you feel less self-conscious,
Hmm.
but you're you're allowed. I don't care how long it takes you to eat. I don't
Right.
care if you're the last person. And the people, I will quote my dad, and he got this quote from somebody else too. The people who love you don't mind,
Right.
and the people who mind, they probably don't have your best interest at heart.
Yeah.
And let them talk, because what they have to say is a reflection upon them in their brain, not a reflection upon you. It's like you choose what's right for you,
Sure.
and anybody else really has nothing, can say nothing about it. I
Yeah.
mean, just be you to the gloriousness of you, because you are the only you that exists. And if that you is drooly, I love you anyway.
Yeah. Exactly. And I think that um, the people that you really, really, really care about, and those are the people that don't mind, and they they either don't notice it or they kind of look beyond it or look through it. So
Yeah, and even if they do notice it, they're likely trying to think of a way, how can I help?
yeah,
I
yeah,
mean, I give people the benefit of the doubt. How can I help? What can I do to make you feel less self-conscious? Do I not bring it up? Do you want to talk about it?
yeah.
Right?
That's that actually brings up another thought that I hear a lot in my clinic is, whether it's drooling, or whether it's something called dyskinesias, where a patient is moving a little bit too much, they're wiggly,
Mm-hmm.
or some other symptoms. It's so interesting because even sometimes I will be in a clinic room and the dyskinesias bother me. They seem to be a little bit too much,
Right.
and in my brain I'm like, surely they want these to be treated. But then you talk with them, and maybe the caregiver's like, oh gosh, the dyskinesias are so bad. But then you ask the patient if they're bothered by the dyskinesias, and not unoften the patient will say, "What dyskinesias? Like what do you mean? I don't. I mean they're kind of there, but
Yeah.
and so it's as a caregiver or someone who loves someone who has Parkinson's disease, I think it's important too to remember that what you may think they're bothered by is not necessarily truly bothersome, and so let's say drooling, for example, or dyskinesias. If you're sitting with a loved one who has Parkinson's disease, make sure that you're not the one bothered, right?
Yeah.
If they're not bothered, then you should not be bothered. If it's a safety issue, okay, that's a different story. But if they're not really bothered by it, then you should not be bothered nor embarrassed by it. I laugh sometimes that I think that um, I don't think it's ever out of malice, but I think that oftentimes caregivers can almost expect too much good or too much perfection out of their loved one's disease, and so these are challenging conditions, and sometimes the patient themselves actually has come to terms with it quicker than someone's caregiver has, and so
Mm-hmm.
that's I think that speaks a lot about how much the love of a caregiver. But it's important, I think, to remember too that a caregiver's role is to really make sure that it's all about the person being cared for, and really try to get yourself out of it, and to make sure that the things you're bothered by are really all focused on the person and not necessarily focused on me. I know that if I was a caregiver, I honestly think I would have a really, really hard time not prioritizing my own, wants and needs and desires for them.
Right. Yeah, I'm thinking as you're saying all of this, I'm thinking about one of my clients, and I think, again, we could spend a whole episode just talking about caregiver challenges.
Sure.
But it's very challenging because you have to know when to step in and assist, and when to back away and allow for independence. And that I tie that into what you were just talking about, it has to be about their independence, not what you want them to be independent with. And that is really, really tough for everybody to handle.
Yeah. But that's part of the role.
It
And
is.
but even the people who are caregiving, they're not alone. There are resources out there that can help. I think that's one area where it's like there's certainly limited, not limited, but like I think that oftentimes the system that is set up for caregiving in America is just not the greatest. Like we oftentimes don't have enough ability to help the people, at least financially help them, because
Right.
insurance does not pay for the level of caregiving that we thought that it would pay for whenever we needed it.
Yeah.
And so that can be very frustrating. But it's at least important to voice someone's overburdened nature of caregiving, if that becomes where it is.
Yeah. And sometimes as a provider, we just need to hold space for it. Just like, yeah, tell me. At least I do that within my sessions. You probably try to, but are unable to, given the time constraints that you're under. But even to just hold witness, what you're doing is really hard, and you're
Yeah.
doing a great job.
Yeah, I think I totally agree. I think it's important. I don't think that's one of my strengths. I certainly try to do it. I understand that idea. I don't know if I'm the strongest there. I think that's something that I'm trying to kind of remind myself. Even in a visit, there's just so many competing interests. Whether it's, the perfect example, I'm sure you run into this, is, you really want to make a patient, because they're important,
Right.
because they should feel empowered. And so I always really like to let the patient try to speak first about their symptoms. And sometimes that's challenging for a patient to really vocalize, whether it's the pace of their speech or the volume of their speech, or maybe it's just really hard for them to get their thoughts together, and then there in turn get them out. And so yeah, I think it can be challenging for the patient. It can be challenging for me. It can be challenging for the caregiver, and it's just really kind of like almost like just got to try to do your best job. Everyone in the room, assuming best intentions, that we're not trying to hurt anyone, but we do need to get the information, and we need to get the correct information. And so oftentimes that looks like, for me, allowing the patient at least a little bit of time to try to express themselves and get the idea out. But always making sure that we remember that we all kind of need like a 360-degree view of every situation. So it's always okay to I think it's always okay to let the caregiver kind of chime in as well, to make sure that their view of the situation has been voiced as well.
Yeah, that's a really good topic that we could also probably spend another whole podcast talking about, is the difference of self-awareness and perception that people with Parkinson feel. It's well documented within the speech research for voice. A lot of Parkinson's patients don't believe they're speaking any softer than they used to. It is the people who are listening to them that are hard of hearing.
Yeah. Yeah, it's the brain is a wonderful organ. Of course, I think it's the most important organ.
Sure. Me too.
But it's also, like, it's so wonderful, but it's just so, whenever the brain changes in the brain, what we call atrophies, or has these changes that we can see in Parkinson's disease or other neurodegenerative diseases, this kind of wonderful organ becomes this frustrating organ, and it becomes like, gosh, why are these connections being dropped, and that can be very challenging and sad.
Yeah, definitely. So to start wrapping up, because you have time constraints, so do I. Um, is there anything else that you want the listeners or the audience to know, think about, any other bits of wisdom or other conversations that we should mark down to have later?
Yeah, I think that I've recently been thinking a lot about how really kind of two sides of the same coin. How important it is for me to show up to each visit as prepared as I can, and so a lot of times patients will kind of ask like, "Oh, did you read this report? Did you see this? Did you see that I went to the hospital? Did you my primary wrote that? Did you see that?" And that's very important. We can't look through everything, but of course, it's important for me to be as prepared as I can.
Right.
But it's also incredibly important, I think, for patients and their caregivers to be equally prepared for the visits that they have with, at least with me, probably with all their providers, all the people that are trying to help them. And just trying to distill that down into a few things, I think would be, as silly as it may sound, I kind of have just started telling people just always bring a written down list of your updated medications.
Yes.
The most important thing that I wish people understood is that the uh, the the medical chart, the electronic chart, is always wrong. It's
Oh
always
no.
wrong. It's never correct. And it may only be only 2% wrong, right? But it's always wrong. And so it's just so important that you know what you're on. Assume that your
Right.
doctor, assume the nurse does not know what they're on, what you're on. Bring a list. That's very, very, very important. And it's always okay to ask your doctor, hey, why am I on these medications? So the first thing is bring a medication list. The second thing, we talked about this, but it's come with questions. There are a few things that I feel like I need to check in on to make sure that you are safe. Otherwise, the visit is mostly yours. And so we can just go through what I call my boring list of typical questions that I want to make sure of. But kind of back to the whole, drooling dyskinesia question, like it really matters what bothers you and what matters to you. So let's focus on those things. Try to keep those Parkinson specific, of course. I'm not really going to be able to help with your orthopedic issues, but a list of questions I think is so, so important. And then also, everyone kind of jokes about how their doctor is always running behind. But it is incredibly important, Michelle, for patients to show up early. And so I kind of hinted at it before, but I was curious, could I kind of walk you through like what a
Yes.
20-minute visit looks like, or what that may look like? And
Please
and I'm going
do.
to kind of share like the bad version of it and then the good version of it.
I think
And
it's
so
very important to know. Yes.
and so this is honestly even kind of a partial request to patients in general, and then to my patients specifically. But so let's say we have a 1 o'clock visit and you have Parkinson's disease and it's a follow-up visit. And the visit starts at 1 o'clock. Well, at least in my clinic at this moment, that means that visit ends at 1:20. And so, but again, like I said, ending at 1:20 doesn't mean really that I'm walking out of the room at 1:20. The system probably wants me to be walking into the next room at 1:20, right? Because another patient's visit is starting at 1:20. And so if patients really want to maximize their time with their physician, or maximize the power of that visit, then here's what they would do, would be to show up early. So if you show up early to your visit, we always say 15 minutes, and we really do mean 15 minutes. Then a few things can happen. That leaves a little bit of time for getting lost in traffic. That leaves a little bit of time for getting lost in the parking deck. That leaves some time to get up to the clinic.
Yeah.
There's always a line of one or two people at the check-in desk. Anyway, so you get there 15 minutes early and you're checked in. That allows my medical assistant to bring you back into your room to go through your medications, really make sure that we understand actually what medications you're on. go through some of our typical required screening questions for all of our neurologic patients, then also start to ask some very specific questions that we ask our Parkinson's disease patients. Those questions are really trying to get a 360-degree view of your condition. Answer those questions, and then the medical assistant will walk out. And then you are perfectly prepared for me, hopefully, to walk in right at 1 o'clock and to spend, as much of that visit as I can with you, answering your questions, making you feel better, to allow me to kind of meet the kind of system expected thought of walking into the next room on time.
So can I just
The
take a
issue,
second?
yeah, go ahead.
So I just want to summarize what Dr. Wiggins just said for everybody. His time with you starts at 1 o'clock.
Exactly.
His time, not your appointment time. His time starts at 1. So your appointment time is really at 12:45 is when you need to be in the room so that you can talk to the nursing assistant to give them all your informations and go through the first part of your visit. But when you're
Yeah.
scheduled with your physician at 1 o'clock, that's when the doctor walks in. So if you don't get there till 1 o'clock, he's now late for his next client after you because you were not prepared for his entry at 1. Okay.
And the other kind of comment I would say on that, and this kind of sometimes breaks my heart a little bit, but if a patient, shows up on time, right, like right at that 1 o'clock visit or whenever their appointment starts, I can guarantee you they're going to feel less cared about. They're going to not
Right.
feel like they had their time. And gosh, Michelle, it's a push and a pull, but the goal is to try to like effectively in the Charlotte Mecklenburg area, the surrounding area, there are a lot of people who have Parkinson's disease. So we're seeing patients not only in Charlotte and in surrounding counties. We're seeing patients from Hickory. We're seeing
Yep.
patients from West Virginia, from Tennessee. We are seeing patients from South Carolina. So there's just a lot of people, and like you said, Michelle, earlier on, like I don't know if we would have chosen the time restrictions that we have, but one of the reasons that those time kind of restrictions, so to speak, exist is that there are a lot of people that need help, and so it's important to show up, kind of in a way of like not only respecting your own time to be like, I want this appointment, I want to have the most optimized visit with my physician, but also realizing that we have to respect all the other patients' times too. And so, it's really, really, really challenging to do this, but I will oftentimes, if someone shows up late, if we even are able to see them, then we'll kind of walk into the room and say like, hey, I'm so sorry, but our time is incredibly limited. We only have 5 minutes, and I'm sure, Michelle, like you've experienced before, behind closed doors or behind the visible, beyond the visible, like one thing that I would kind of remind patients is that squeezing a patient in doesn't really happen. Every minute is kind of accounted for the day, and so we
Yeah.
have patient to patient to patient, and so that's why you don't show up late. You show up on time and early, right? And like
Right.
I would agree with you when I say on time, I mean 15 minutes early, and then not to mention there's a lot of pressures involved. So we not
Yeah.
only see patients from 8 to 5 p.m., we are getting a lot of, and we want to get my charm. We want to be in touch. We want to help. But there's just a lot of pushes and pulls in the system. And so it's really hard to get to everything as quick as we can. And so there's a lot of triaging, a lot of trying to make sure that we're helping obviously the most people, but also the people that need help right now, and really trying to figure out who those people are. And I think that is kind of where my plea comes in to patients of the best thing you can do is to show up early to your appointment. That will, you know, that'll be make everyone happier and
Well, yeah.
make the visit go a lot smoother. And it's, I think Michelle, and I'll stop talking about this topic in a second, but you had kind of said this earlier on about like, you were speaking about it in kind of a cognitive, or sorry, mental health, like anxiety. It's like, it's so good to get up and do something for yourself, Well, I would say similar, like, it is good to show up for yourself.
Yeah.
And one way that happens is by getting the best appointment you can. And the way that happens is showing up early. I know that when I've showed up right on time for a doctor's appointment, I feel bad. And I oftentimes tell the doctor, I'm like, I know I'm late.
Right.
You
Yeah.
may have to reschedule me. I will keep it brief, and gosh, it's just so challenging because it's not, no one's lazy in these situations. No one is, mad or like a bad person. It's that it's really hard to walk quickly. It's really hard
Yeah.
to get someone up and out. And I get that. I get that. That's kind of the whole idea of don't plan on showing up at 1 o'clock. Plan on showing up at 12:45, 12:30.
I was gonna say 12:30.
Yeah.
Plan on
Yeah, I
showing up
mean,
at 12:30.
I like to say plan for Charlotte traffic, right?
Oh
It will
man.
be bad. It will be worse than you expect it to be. So I'll quit talking on this topic, but again, I just want to emphasize that it's really a how do we help both the individual as much as we can, as well as help the most individuals as we can,
Right.
as efficiently as we can, while remembering that each individual person is valuable and to be cared about and is to be dignified.
It's an intricate dance, as I like to say. It's an intricate dance. We got into this field because we care about people. We want to help people. We are good at what we do because we take pride in our craft, so to speak, right? And a pride in our education. And at the end of the day, we just want to help as many people as possible. On the other side of that, there are a lot of restraints that we are held to. So I will use myself as an example, and I know that this can carry over to physicians as well. Working in skilled nursing for a rehab company, we are held to productivity requirements, which theoretically sound so simple. But in a 120 bed facility where you have 20 patients that you see 5 days a week, that means you have 40 to 50 nurses that want to be updated and family members who come in and want to talk to you. And so when they say productivity, they're talking about patient care time. So I can only bill, well, it used to be, it's changed a little bit now, but I can only bill for services if the patient is in front of me and I'm providing a skilled service. And family education is a skilled service. However, sometimes it's not always appropriate to be talking about things in front of that patient.
Mm-hmm.
Sometimes caregivers, family members need to tell me things that they don't necessarily want that person to know. So you get pulled out, you get pulled aside, not to mention you get to run around the facility trying to find someone who's not in the bathroom, who's not with nursing,
Right.
who's not with PT or OT or out to the doctor or wherever, right? So productivity requirements are very, very difficult, and then we have a certain amount of time that we're scheduled with these clients, and we're supposed to stick to them regardless because there are so many other people that need to be seen. And when we don't meet those requirements, and you talked about doing your notes are the bane of my existence. I do my notes on the weekend and I hate it. That's the part of the job that I hate, is that I cannot get my notes done because I'm providing quality care. I'm paying attention to what they're saying, and it's not always easy to work with somebody on cognition if I myself cannot focus my own attention because I'm trying to write a note, right? But on the provider end of that, we get in trouble. We get written up.
Yeah.
And that's why I left. I got tired of being written up. And certainly physicians can't do that. Otherwise, you would never have a job, right? I mean, so I think it's important. It's so important for our patients and our family members to recognize that external pressure and expectation, and why we're talking fast and why we're not necessarily interrupting, but trying to redirect the conversation to the things we need to know about when you talk about knee problems and orthopedic stuff. We care about it, we really do, but boy, we are under a time press, and that is why it's so important for you to show up early to make sure that you have the amount of time that you want, because you hit the nail on the head. When they don't feel cared for, and that is not what you and I are about, right?
Yeah, I understand a lot of what you're saying, and I think that yeah, it's a dance, and it's certainly challenging. I would say that, like, no one went into this field to or I don't really know many people that go into medicine or speech language pathology for a reason not to help people. So that's always the goal, and yeah, it's certainly challenging to get all of the things done. And again, I would say this is that it's this is maybe kind of geared more towards healthcare providers or people in the field. It's a marathon, not a sprint. I think that I have to remember that the reason that I'm here to help my patients with Parkinson's disease is hopefully to be here with them in 5, 10, 15 years, to be treating them and to be their same doctor, and to be the same one who diagnosed them with Parkinson's disease. And now I'm treating them with deep brain stimulation 5, 10, 15, 20 years, right? That is kind of the goal. That's what everyone wants. But from a provider perspective, or provider to provider, I think the idea is, like, how do I make that happen, right? I don't know I don't know what the future holds. I don't know if I will even be in what we would call kind of clinical medicine in 1, 2, 5 years. I just don't know. But the goal is to try to be here for as long as I can, and help as many people as I can for as long as I can. And so I have to, and you have to, and we have to take care of ourselves and protect ourselves, just like caregivers do. Yeah, there's, I think the theme of the day, Michelle, is there's so much more that could be said about this topic, but I think I'll kind of leave it there. But ultimately, the goal of the overwhelming majority of healthcare providers is to help and to care. And I oftentimes try to remind myself that, but also just want patients to understand, like, if there was a feeling of, oh, they don't care, it's probably because of a misunderstanding.
Yeah. I think that's a great way to end it, is that we care. We want to be here. We play by the rules. Most of us, you do. I make my own. For now. So where can people find you?
Yeah, so I'm at Novant Health in Charlotte, North Carolina. Novant Health has several locations in Charlotte, as well as kind of throughout the Southeast, but I work kind of closest to uptown Charlotte. So you can go on to Novant, I believe it's novanthealth.org. You can search for Robert Wiggins, MD neurologist. I also have a Substack, which I believe it's substack.com/Parkinson's Primer. My Instagram handle for my neurology side of things is Robert Wiggins, MD. So yeah, feel free to follow me on any of those channels. And I'm also running the Chicago Marathon coming up here in October with the Michael J. Fox Foundation. And so if you're interested in supporting me and or the Michael J. Fox Foundation, feel free to support me there.
Absolutely. Thank you for your time. And I will try to link all of those social in the show notes and all of that fun stuff. I appreciate you as always, and I look forward to our next conversation.
Absolutely. Can't wait. Thanks, Michelle.
All right. Thank you, Robert. What an amazing conversation I had with Dr. Wiggins from Novant Health. As you could see, the episode kind of took a turn away from neurology and Parkinson's, and we really wound up talking about the beyond the visible of your doctor's visits and why things may feel rushed, and reasons for why you might not feel cared for, and ways to adjust your scheduling in order to make sure that you get the most out of your doctor's visits. Because at the end of the day, Dr. Wiggins and myself and the other healthcare providers that will be featured on Beyond the Visible, we get into it to help people. And we are trying to do our best to see a lot of people, as many people as we can, as fast as we can, playing by the rules to the best of our abilities in order to do that, so that we can be around in 5, 10, 15 years. And I just think that that's really important for everyone to know and understand. I'm so proud of this episode, and I am so glad that you joined me for this episode of Beyond the Visible. If something you heard on this episode really resonated with you, please consider subscribing, sharing, liking, giving it a review. It helps other people with neurological disease, Parkinson's disease, family members, even other healthcare providers to be able to find us. So, until next time, keep going, keep questioning, keep believing in the best of intentions, and keep looking beyond the visible. We'll see you next time.